My name is Ari Jenkinson. I'm with the UWA Medical Physics Group, and today I'm going to be presenting my research proposal on 3D printed brachytherapy nose surface applicators with eye shielding for clinical use. So I have two supervisors. I have Dr. Pejman from the University of Western Australia, and I have Luke, who's a part of the radiation oncology at Sir Charles Gairdner Hospital. So to begin with, I was going to start talking about brachytherapy and some of just the basics around that. So brachytherapy is mainly a radioactive source placed within a close proximity of a cancer. As you can see in the slide here, there's a lot of different types, but in particular, ours, and which I'm going to focus on, is a non-invasive brachytherapy. And of course, here's a photo or kind of just an example of how it would look like in particular for my case. As we can see, the surface applicator is placed over this phantom and it's running up and over. So there's also another important part of brachytherapy, and that is, of course, the dose rate. So we have low, medium, and high, and also pulsed. But in terms of what I'm focusing on a high dose rate brachytherapy. So, of course, that's all we need to know. So in particular, I'm going to jump straight into treatment. So say we have a patient and they're diagnosed with a superficial nose cancer, and in particular, they're going to undergo contact brachytherapy or non-invasive brachytherapy. The current method in place at Sir Charles Gairdner is the bolus method. So the bolus method starts with the patient being 3D face scanned, and then of course, this is going to be milled. From there, a radiation therapist will take the milled face and then they will start applying a layer of aquaplast bolus onto the milled. And then, of course, they're going to place their applicators or their catheters, and then they're going to glue it through wax and a bunch of different procedures. And they're going to then mold a second layer on top just to make sure that they stay put. So from here, we can get the CT scan of the patient just to confirm the brachytherapy treatment planning system, and then they will undergo treatment. However, the bolus method is quite outdated and it's not too good anymore. In particular, it's prone to air cavities and it has a lot of random variations of thickness. In particular, if you just look at the image of the CT scan here, you can see these gaps and you can see how non-uniform this surface applicator is. And that's really bad because when we're planning this treatment, we want it to be as perfect as possible. We don't want any air gaps. We want it very uniform, and we just don't want random thickness. Above all, it also takes a lot of time. Milling can take a while, depends on the availability, and also after it's milled, then we have to get a radiation therapist in to work with it. So the bolus method overall, in terms of what I think personally and how it works, it's not too good. Instead, we have this better new applicator, which is currently undergoing TGA approval at Sir Charles Gairdner, which is 3D printed surface applicators. So 3D printed surface applicators is very similar to the bolus method and bolus applicators. However, instead of milling it, we will of course print it. So we will print a surface applicator and sometimes print a phantom, depends. And we will model this. So what comes with modeling this instead of having a radiation therapist model it themselves is that we can have reproducibility, we have uniformity, we don't have air gaps. It's created by a machine, not a person. So it's very perfect and it's very accurate. So here on the bottom right is some data taken from another master's student, in particular Warwick. And as we can see on the bottom right or the far right-hand side, this is our treatment plan to our actual outcome. And as you can see, it's pretty much perfect. Our treatment plan was right on what we wanted to give. And there's not a large variation between the two. As much as we love it, it is very good. However, there is kind of one problem in particular, if you can see with this, is that the way the catheters are going, the catheters are going to run over the whole entire face. In particular, it's going to run over the eyes. And eyes are very radiosensitive, and as a problem, this will induce radiation cataracts. Warwick was smart enough to undergo and understand kind of the problems with this, and he also took measurements where the eyes are. And as you can see, this red line is a 5 gray, and it's meant to state at what level will induce radiation cataracts. And as we can see in our far right, this person will definitely get radiation cataracts. So that's kind of where I come in, and I want to start exploring better methods to stop this radiation cataracts. In particular, I want to start with eye shields. So eye shields can be just placed under the eyelids and they go into the eye. It's very simple. I think the ones we have at Sir Charles Gairdner are tungsten, and they have been somewhat used. And yeah, so overall, the idea behind it is that we're going to chuck these into people's eyes and it's going to shield from the brachytherapy radiation. Hopefully this should be better because of course it's just an improvement compared to the last, because now we have actual shielding, whereas before we didn't have any shielding. So all the dose would just be going into the eyes. However, this brings me to a new point, which is what I wanted to kind of focus on in particular with my research more, is I want to focus on tungsten shielding from a 3D printer. So 3D printing has come quite a long way, and now to the point where we can print a high amount of tungsten and we can just print this. So the idea behind this is that if you see this surface applicator on the left, is that any part that doesn't need dose, so any normal tissue, we could just have this bottom layer be printed in tungsten. So we can just shield the patient and of course increase that therapeutic window. And this kind of brings me to my final point, which is kind of a combination of the two. So maybe a combination of both eye shielding and then also tungsten 3D printed shielding. And is this necessary? I'm not sure. Maybe eye shields would just be enough, or maybe tungsten shielding alone would be enough. However, I want to explore this in my research. I want to take numbers of, in particular, half value layers and things like that. Now, this might be a bit confusing, in particular about what I'm going to do. So I thought I would create a bit of a flowchart. So in particular, I'm going to start with just taking eye shield data because I know I can do this at this current moment. We are currently waiting for a new Prusa 3D printer, which will be able to do dual extraction. So basically we can print 2 different filaments at once without having to switch over anything. We can just put it into the machine and it can work itself. So if that comes through, I of course want to focus on 3D printed tungsten shielding. And then if it's worth, which I'll decide with my data, then I'll do both. If not, I'll talk about it. But this is kind of my idea so far. My schedule. So I plan to start most of this project and most of this research starting next year at the 2023 February. So it's still quite a while away, and I plan on working on in particular Warwick's paper and hopefully publishing that over the summer. So a lot of my aims is just to increase patient safety. So I want to increase, of course, or reduce the dose to the eyes. I want to also investigate clinical implementation. So in particular, I don't think any of my project is worth if it's in such a fairyland scenario where it is in such a hard way that no one can ever replicate this. If no one can ever replicate it and requires so much knowledge, then I don't think there's any point in doing it. And of course, I want to investigate 3D printed tungsten shielding. In particular, the point behind that is that we're currently just focusing on the nose and in particular the dose to the eyes because that's a very radiosensitive part of the body. But imagine we're printing for some other part, in particular an ear. We can't exactly just use an eye shield for the ear. We have to find other ways to shield normal parts of your ear. So that's in particular where I'd like to investigate how well our 3D printed tungsten shielding could do, and then how we could apply it to potentially other parts of the body or even just other shielding in general. So some of the benefits behind this is, of course, increased patient safety and long-term cost saving. So long-term cost saving in particular is about not having radiation cataracts ensue. So if radiation cataracts was to ensue, this would cost upwards of about, just ballparking at $3,000 because of how much manual labor is going to come into cost. We're going to have to bring back in the patient. We're going to have to organize a surgery. There's going to have to be a lot of cost associated with that. So if we can not have the patient have radiation-induced cataracts, we can just save a lot of cost. And then also, hopefully, is to be able to apply it to other just 3D printed shields, and that's in particular more so the tungsten. It's very interesting. As of right now, there's kind of a lot of talk into 3D printed tungsten and how far that can go, but we'll talk about that later. A couple of the problems associated not only with my research, but also my research in general, I guess, is 3D printers. As much as I love them and as much as they are a part of my research and my project, 3D printers are also bad. They can break, they can just be misused, they require knowledge. 3D printers are a bit, as they are good, they are bad, I suppose. Some knowledge of modeling is also going to be required, in particular to undertake creating 3D printed surface applicators with eye shields or with tungsten. There is, however, a protocol currently for 3D printed surface applicators at Sir Charles Gairdner that I know. So it requires less knowledge, but it still does require knowledge. So what research is currently being undertaken? So right now, there's actually quite a bit of research. Sorry, my slide didn't pop up the way I wanted to. But basically, there's 3D printed surface applicators have been going around since about 2016. However, more recently, even a research paper published quite literally last month is talking about tungsten shielding and printing 3D printed shields, in particular for PET scans. So that's why I kind of want to focus on tungsten shielding as a whole, because we can apply this to any sort of radiation shielding, and if it's good enough, yeah, the sky's the limit, I suppose. Also, 3D printed surface applicators for nose in particular. There's a Polish guy and a Polish group who's doing a lot of research into it. In particular, they've been focusing on very high complexity spots such as corner of the eye, the nose, and of course the ear, because all of these spots are highly complex and require a lot of, I suppose, modeling. So some of the costs associated in particular is mainly just the 3D printing. The most expensive cost is the tungsten filament, I suppose. This costs about $1,000, but in the grand scheme of things, we won't be using a whole roll for a patient. And in particular, when measuring the costs of a roll of tungsten filament and then, of course, a radiation cataract surgery, one is way higher than the other, which is the surgery. So the idea of these costs is that these costs should stay lower than what would be needed in particular for post-surgery, I suppose, of brachytherapy. Also to note, a lot of these costs we've already got. So we've already got a lot of nozzles at the UWA Medical Physics Research Group provided by either the hospital or UWA itself. So we are quite lucky in the sense that I will not need to spend all of this. Other than that, I want to say thank you. And any questions?
Okay, thanks, Ari. So we have first question from Zaid. And Mario. So we can hear Zaid now. Maybe Zaid is muted.
Oh yeah, sorry, I'm muted. Thanks for the nice presentation. I have a quick question about the this shield, internal shield in the eye. Are you going to use which algorithm you are going to use? Are you going to use the TG43 or computer-based model like Accurus for this kind of, because you want to estimate also the dose, the effect of this shield in your plan. So is it going to be shown? Is it going to be calculated by the TPS, or you are going to do some other kind of measurements?
I suppose we're going to take mainly measurements with phantoms. In particular, I know the treatment planning system at Sir Charles Gairdner is still under TG43, so it still assumes everything is just water. So when we take measurements in particular, I won't be taking measurements with patients. So what I might do is just place film, let's just say, underneath the shields just to test, and then we'll see the dose behind that. So we'll create a phantom and then
because
measure beneath that.
we have another algorithm anyway, which take into account the heterogeneity, but we are not using clinically yet.
Yeah.
But who knows? Anyway, thanks.
That's all good.
Can-
If it does
yeah.
change,
You can use it for research.
but if the treatment planning system at Gairdner does change, which from the people I've talked to, I'm unsure if that will happen. But if it does, well, I'll just use the new one. That's all.
I think Zaid's suggestion is good, and because we're doing research, you may run them in parallel. So you may have, because you can run using TG43, and you can run under the other Accurus algorithm. And for research, I think that's very nice to have that kind of comparison. You may want to add that to your work plan.
Okay.
It's good.
Thank you.
Excellent, Mario.
Hey, Ari, thank you very much for the presentation. It's very interesting and very good clinical application, I think. My question is basically on the actual shield, because you were talking about grays per hour dose rates. The eye shield or the radiation source is very close to the eyes. So have you done, basically, do you already know like how much shielding roughly order of magnitude you will need? Because it doesn't take much to induce radiation cataract. And so basically, how much tungsten shielding would you expect? And my second part of the question would be, do you see any issues in mechanical integrity when you print a fair bit of tungsten for the eye shield?
So as of right now, I think that the eye shields are about 5 millimeters thick. So it's 5 millimeters of tungsten, which does some amount of shielding, which is the eye shields, I believe, that are in use. So that would not be enough. It would reduce it, but it would not be enough. So about, depending on the thickness of what the surface applicator will be, which is sometimes up to about a centimeter or so. And if we can just print that all, that's another centimeter. So that's about 15 millimeters, which should stop majority. It won't stop all of it, of course, but it will stop more. And the second part of the question, sorry, can you repeat it?
Thank you. Just about, because it sounds like a lot of tungsten, do you foresee any issues with mechanical integrity of the eye shield when you print it?
Yeah, so that's something I want to explore. We can't as of right now because we don't have the printer. We can print tungsten in as of itself, but we can't print tungsten in tandem all in once. So in particular, if I pull up this image, the idea is to just 3D print. So basically we can print both PLA and tungsten at the same time with the new printer. However, right now we can only print one at a time. So whether the tungsten will be structurally sound, which so far through printing, it has been fine, but whether we can get it to work while printing both PLA, I mean, if we can get the new 3D printer to work with both PLA and the tungsten working in tandem is a bit of a gray area because we don't have it yet. So there's a bit of a we don't know yet, or I don't know yet in particular.
Excellent. Thank you, Ari.
Ari, just one comment I have. It's not much of a question. It's more comment. You talked about the eye shields and that they go under the eyelid. But is that always the case? Do they always go under the eyelid? Or sometimes?
So I believe not always. I believe they can rest on top of the eyes,
Yes.
which is what I'm assuming is the one on the left, and then the one on the right is in particular to go under the eyelids, and then they can pull it out with the top part.
You could still use the one on the right for putting it on the eyelid.
Okay.
Yeah. So there is one concern that I'm not sure in this energy range it would be valid or not, but the backscatter from the tungsten to the eyelid, I think you need to evaluate that, or at least read to see if there is any considerable amount, because it is in high energy beams, like high energy electrons. Basically, that's what we have. I'm not sure if in the energy range of the HDR source you would get any considerable amount of backscatter. So that's one thing to look at, so that you don't overdose your eyelid.
Yeah, but as of right now, even introducing, I suppose, any shield would be better in particular, because we're more so focusing on protecting the eye, and in protecting the eye and stopping that radiation cataract surgery. But that is a good point. I need to explore into that as well in my research.
You don't want to overdose the healthy tissue.
That's good. Brilliant. There is no more questions. If you could please, Martin, turn off the recording.